So today we're going to talk about something that's extremely important, obviously not only to the child that has a burn injury, but can be applicable to many trauma patients and septic patients. Obviously, the aspects I'm going to focus on are particularly pertinent for the child with burns who becomes septic, because sepsis is the ongoing risk for us. And failure to identify the child who is becoming septic or is severely septic obviously has very significant outcomes. And you can't do the right management if you can't identify the problem in the first place. So we're going to go over some simple things today in an effort to try and help you to recognize that sick child. And step one is the end of the bedogram. Now, those of you more experienced will know exactly what I'm talking about. For those of you that are younger, this is the end of the bedogram. And I think the pictures will tell you themselves what I'm talking about. But it's literally the impression that the patient gives you. And clearly the kitty on the left is doing well and there's not a problem. And the kitty on the right is extremely unwell. And you need to be able to walk into the ward, screen the room, and identify, for example, that child on the right-hand side and go immediately to get more information and to see what's going on. But you should be able to, even without any objective numbers, be able to see that is a sick baby. Some of the signs and symptoms you specifically need to look for and ask about is lethargy versus a completely flat child. Is the child irritable and more irritable than usual? If you've been listening to us talk on burns for a while, you'll know that GI disturbance is a really specific marker for us, and for me, really pathognomonic of sepsis. But you've got to inquire about the diarrhea. You've got to look for abdominal distension and vomiting, but I find that is often less than the other two. The tachycardia, our patients are generally tachycardic. There's a number of different reasons for the tachycardia, but sepsis certainly must cross your mind. And you need to be able to go back and look at what the normal sort of tachycardia for this child is. What was it this morning? What was it yesterday? If the child usually runs at 150, then that's not a problem. But if the child is usually at 150 and now we're at 180, we're in trouble. Certainly any child with a heart rate above 190 or 200, there's something up, and you should look closer to see what's going on. A heart rate that high is a problem. Tachypnea, I think it's often not measured, or sort of the nurse's observation charts are relied upon. Don't do it. You need to look at the child. You need to count the respiratory rate yourself. Can be difficult. Sometimes there's lots of bandages around the torso and you can't see it, but you've got to count it. You've got to look for it. Look for the accessory muscles. Look for the nasal flaring. So is it tachypnea or is it respiratory distress? Check the sugar. We know that high sugar can be associated with sepsis, but what the killer is hypoglycemia, and that's obviously something imminently treatable. So in any child where the end of the bedogram tells you that the child is sick, you need to go and do a HGT. Capillary refill, and we're going to go into a little bit of detail about this because I think people are not doing it, and sometimes I wonder how well patients are really getting examined. and I would really encourage you to be hands-on. Capillary refill can give you a lot of information. The same as the temperature and the color of the hands and the feet. Poorly perfusing children, their hands and their feet get cold. By the time they're cold, you're often in deep trouble. And then you want to gauge the edema. Is there some periorbital edema? And again, I'm going to talk a little bit about this versus generalized edema. And then, of course, the color and the quantity of the urine can also give you a lot of information. And here you see it. The picture on the left, these purple toes. So even going one step back at the bedside, you actually have to take the blanket and the sheet off the child and look at the whole child, look at the toes. If you see that, that should make you worry. This child is in deep trouble. And then if we go to actually doing capillary refill, so this child's color looks quite good, but if you see there how delayed that capillary refill really is. And I'll show you again, you need to press fairly firmly for 3 seconds before you take your finger away. And that is a lot longer than 3 seconds. I find doing it on the heel of the foot, or here you see the hand. So this is to compare normal brisk capillary refill. 1, 2. That's what we want. Use the palm of the hand, and there's demonstrating just how dry that child is. Look in the mouth. He looks quite lethargic. So that's, the whole picture. The capillary refill is good, so we don't think that child is shocked, but we certainly think he's dehydrated, versus this child's 1, 2, 3, 4, 5, 6. That is a shocked child, and you need to act immediately. And even here, the blue toes, you don't even need to do capillary refill to know that you're in deep trouble there. So really, you need to do it on all these kids. Then another very useful source of information is the monitor. And if I ask you the monitor on the left with the heart rate of 126 and the SATs of 77, what do you think about that if I tell you that it's a child with 30% total body surface area burns? The child is 18 months old, and we're on about day 5. Don't think that there's a problem with the monitor. There is, in fact, a problem with the child. The SATs trace is flat, it's poor. That's not a true reflection. I don't think hypoxia is the problem. The problem is lack of perfusion. So it's not picking up the SATs. The heart rate, a heart rate of 126 beats per minute is just not appropriate or realistic in an 18-month-old child with a 30% burn. So it's not picking up the pulse. The pulse is probably much higher than that. And a picture on the monitor like that should prompt you to go and examine the child and not run off and find a monitor. And your primary diagnosis here is poor perfusion versus the monitor on the right. There's a very good trace. So the SATs are 81, the heart rate's 130 something, blood pressure looks reasonable. The trace is good. This child is perfusing. The problem is saturation. And then sort of what you're looking for and how you managing the child imminently is based on hypoxia rather than, for example, the poor perfusion on the left. But it can be quite challenging. And for example, this is demonstrating a very irritable child. And while pain must certainly cross your mind, and that's easy to sort out, give the child some analgesia, see if he settles. Otherwise, again, sepsis should cross your mind as this primary diagnosis in the child. Now I'm going to ask you just to look at this video and to tell me or think about in your own head what you notice immediately. What are the problems that cross your mind? Okay, I'll let you watch the video again. Okay, and now I'll talk you through what the problems are. So first up, that abdomen is awfully distended, and you'll notice that the child is in a head-up position. Tachypnea is a big problem. Those eyes are swollen. He's in a bit of an awkward posture. The SATs are 100. The heart rate was 166. So one more time. So his abdomen's distended. We prop the kitty up to try and remove or take the abdominal contents away from the chest. But he's definitely tachypnic. He's swollen. Heart rate of 166 doesn't seem too bad. SATs are good. And urine's reasonably clear. And this is just, gives you a lot of information to process. We need more information to get to the bottom of what's going on. But certainly the end of the bedogram is telling you that this is a very sick baby. Also, just a word on I hear a lot of people saying, oh, the kid's overloaded when we see him at the bedside like this. Now, edema is not equivalent to overload, and there's a lot of different ways to describe it or terminology. Certainly, he's got periorbital edema, and I find the kids tend to accumulate the fluid, especially if they're lying flat around the eyes and around the groin. I often get called, 3 o'clock in the morning because the scrotum or the vulva is extremely swollen. Those are the dependent areas. That's where the edema will go. Children that get septic switch on their ADH, so antidiuretic hormone. They hold onto their water. So some soft tissue edema is completely normal, and it's often just reflecting that the child is sick, and we are sort of embarking on some fluid resuscitation, and they retain that water. As they get better, they start to pee that out. But you need to decide on, is this just edema, or do you really think this is fluid overload? And then what do you mean by fluid overload? And really we're talking about overload that would push somebody into cardiac failure. So you want to look for the signs of cardiac failure. In kids, you can feel for a big liver. It does happen. Maybe a little bit more common would be pulmonary edema. And again, you're looking for a deterioration in the SATs. So potentially we're giving aggressive fluid resuscitation and the child was not on oxygen. Now we go and review and now he's on oxygen. So there's a degree of hypoxia. Fluid overload, pulmonary edema should cross your mind. Is he more tachypnic? You need to listen to the chest. Are there creps? The creps might come quite late. What you might hear before that is some wheeze. That should make you think, are we starting to overload the child? But you've got to look at the whole picture and really to caution you against labeling a patient as being overloaded. There's also a difference between having, lots of soft tissue edema, you're sick, you're getting lots of fluid resuscitation, and still being intravascularly deplete. and being shocked or being behind. And it's difficult, but you must try and separate these two problems out. So really, when you're looking at the sick, burnt child, the question is this sepsis or is this not sepsis? And almost always, it really is sepsis. If it's in the first 48 hours post-burn injury, we could consider that the child is sick because it's an acute injury and a fluid resuscitation issue. It could still be toxic shock in that first 48 hours, but you really have to investigate for sepsis and prove that it's not. So just a couple of practical tips on how to go about addressing some of the problems in the sick and septic burnt child. The first one is resus. If the child is shocked, and remember their blood pressure will often only change really quite late, but a capillary refill of 4, 5, 6 seconds, that is shock. And shock, the treatment of shock is to bolus them. Some of the guidelines bolus with 40 mils per kg. I would prefer to bolus with 20 and then repeat the bolus, and we're using Ringer's lactate. Then you need to assess where they are. Are they somewhat dehydrated or severely dehydrated? If it's a shocked child, I would call them severely dehydrated, and I would, after the bolus, run them at 4 mils per kg per hour of Ringer's lactate. If it's not a shocked child, but for instance, the video in the beginning was good capillary refill, but the mucous membranes looked quite dry, maybe we're saying there's definitely some dehydration and we need to start Ringer's lactate at 2 mils per kg per hour. And then depending on the HGT, you may or may not add dextrose to that Ringer's lactate. You also need to account for ongoing losses, and in our patients, it would particularly be a septic wound with a high exudate, and maybe that's accounting for their losses, and commonly diarrheal losses. And we can very quickly get behind by not accommodating for those losses. Then the last question about fluids and resus, you need to ask, do we have feed intolerance? That kitty with a grossly distended abdomen, that nasogastric tube needs to be on free drainage and feeds need to be stopped. So then we definitely need to give maintenance on top of that severe dehydration regime of 4 mils per kg per hour of Ringer's lactate. How do we work out maintenance? That's the 4-to-1 rule. So 4 mils for the first 10 kgs, 2 mils for the next 10 kgs, and then 1 mil for every kg after 20. And that is per hour. Some of you may know it as the 150-20 rule. I prefer working it out per hour. If we've got feed intolerance, abdominal distension, and that NG is on free drainage, you definitely need to be adding dextrose to this maintenance fluid. And for ease of working it out, I would work out the 4-to-1 rule plus the 4 mils per kg per hour as a total rate, and then just add the dextrose into that. Not every sick child feeds need to be stopped. Some of them are quite sick, but their abdomens are completely non-distended. In that case, you don't have to stop the feeds. If there's diarrhea, you can still continue feeding. It's really about looking for that abdominal distension. And obviously, if they're vomiting, you want to stop the feeds. And then nursing them head up. That big distended abdomen, all the edema you see peripherally is also in the gut. And that, if the patient is lying flat on his back, that is compressing the base of the lungs, and that's going to exacerbate the basal atelectasis and or any pneumonia and make more problems. So be sure to position your patient correctly. It's a simple bedside thing to get them, and in the little babies, it's really basically the whole body up. Electrolytes, so they often have huge electrolyte derangements. The common ones, potassium, magnesium, and phosphate. Those need IV replacement, and we shouldn't be faffing around with mist pot claw. We need to give it IV. All of those sort of formula are in our protocols. Also a word on hypernatremia, and in burn patients, it's generally a loss of water problem and not an excess sodium problem. Obviously, there are always exceptions to the rule, but really it's generally a dehydration problem, and they need resus with Ringer's lactate, or some of the protocols say saline, but it's a balanced salt solution, and it's not a hyponatremic solution. Also, just to reiterate, Shelley has said it before in many of these tuts, we do not use half DD to resuscitate children with burns. And then just another word, typically the patient who becomes septic will develop a metabolic acidosis secondary to poor perfusion, and you will see a large base deficit, the bicarb will be low, and the lactate will be high on the gas. Now, if you've got an acidosis, but your lactate is normal on the gas, and clinically your child is perfusing well, the other thing you need to look for, or as a possible explanation for the acidosis, is a hyperchloremia. And certainly resuscitation with saline Ringers, there is a large chloride load, and they do get hyperchloremic. Potentially acute kidney injury is another component of that acidosis, and I mention it just because we had a case yesterday. Typically it would be poor perfusion, but just to have that in the back of your mind. Now again, to go back to the edema, remember they're sick, they turn on their ADH, they hold on to the water, so a degree of edema really is normal. As they get better, they will start peeing it out, but it does take time to resolve. You've really got to try and separate out that edema from true overload. In general, if we're talking about the septic kid who's also edematous, they're generally behind on fluids. Do not give Lasix. Do not give Lasix for the edematous child. That is one sure way to kill the baby. You're going to take a child who's already sick and make them more intravascularly deplete. We don't use Lasix to resolve edema or to get a urine output. And then just another consideration, you know, the use of albumin and blood products in the anemic patient are part of the protocol of resuscitation. And certainly they stay in the intravascular space a lot better than crystalloid fluids. So there is a role there, but I'm not going to go into too much detail. And then just to go to airway and breathing for a moment as well. You have to pay attention to the child who has stridor. And it's a very different scenario, the child who presents to the emergency department with an acute burn that's maybe to the face and the neck, and there's external edema compressing, and that's the acute reason for stridor. I'm talking about the stridor maybe a few days down the line, especially face, neck, chest burns, a big burn. They've had a lot of fluid resuscitation. They're prone to sepsis. They're prone to upper respiratory tract infections, which itself can lead to sort of edema of the upper airways and inflammation. You've got to look for neck edema. You've got to pay attention to the stridor. If there's bandages on the face and the chin, you need to cut those open. It can often relieve a little bit of extra compression is by cutting the bandages underneath the chin or around the neck. The other thing you need to do is nurse that child sitting up and start adrenaline nebs. But you do not leave the child's bedside until you've got either an improving problem or a definitive airway. And you really need to consider the need for intubation. Then obviously oxygenation problems, dropping SATs requires oxygen. You have to ask yourself, why are they requiring oxygen? What is the problem? Because the treatment is different. Is it a pneumonia? They need antibiotics, aggressive chest physio. Is it pulmonary edema? In which case your strategy of fixing that problem might be quite complicated. But you want to understand what the problem is so that you can treat it. If they are requiring as much as 100% oxygen, I'm going to say that child needs ventilation. You can't walk away from a child on 100% oxygen. So if you've got them on that rebreather, just a word, that bag must be inflated, and you must have 15 liters of oxygen at the wall. If it's not, then you're not actually giving the child 100%. But if you are, you've got to be you're in deep trouble, and you've got to worry about the child actually needing ventilation. Same with severe respiratory distress and a very high respiratory rate. You've got to be thinking, this child needs ventilation. And then, yeah, the pulmonary edema, we've talked about it already. The wheeze might be a earlier, softer, more subtle sign to pay attention to versus the obvious frothy sputum. Ideally, we don't want to get to the frothy sputum, and we would like to pick it up while there's that wheeze. So just to conclude, it's important to be able to identify the sick child, because that's the difference between life and death and instituting treatment. And I would argue that it really hinges on a good, thorough clinical examination, doing a septic screen, the basic bloods, and certainly a blood gas is useful in this instant to try and understand exactly the degree of how unwell the child is. The history is useful. Ask the mom, what's been happening today with the kid? Get collateral from the nurses, read the notes, look at the charts. It's the whole picture that you have to paint together. In the burnt child, it's almost always sepsis. And then really in airway and breathing, you've got to think about the need for intubation and ventilation. For circulation, you've got to differentiate shock versus dehydration, because that determines the aggression with which you resuscitate this patient. D, the disability, is the child flat or lethargic versus irritable. And then the E, we can look at edema and electrolytes. And that's just a quick summary. Obviously, there's lots and lots of different details to talk about, which we're going to go into, in these tutorials over the next weeks. But I just wanted to give you a brief overview and try and help you identify the sick child. Don't be afraid to call for help.